Well, what I always tell people I do in ICU is the nurses save their life and I give them a life worth living. That's like my slogan down here. I think the biggest thing is that, especially in acute care and in ICU, these patients are so sick that OT is so instrumental of getting in there early and providing the care so that just because you saved someone's life, they can go back to the same life they were living and doing all of our interventions. I think that's really in a nutshell. But yeah, I mean, I think the earlier you start providing independence to people, the better they'll get. And that's what I do. I am in there from almost day one sometimes, just being a cheerleader and doing what I know to do as OT and getting them back to being functional. I live in Indianapolis, so I commute an hour every day for 9 years. When you love someplace you work, you commute for that long. I get questions all the time. So my day starts really early. I get my kids off to school and then I come up to ball. I get here around 7:30. My hours start around 8. But I get here early because we have an interdisciplinary team in our critical care unit. So I get here to look at new orders and to see what my day is gonna look like. And then at 8:30 every morning we huddle, and then we do our interdisciplinary ICU team huddling. So in the mornings I come in and get all my stuff ready, and then I meet with the physical therapist I work with and then our speech therapist, and we round on our patients to see what I'm doing for the day. And that really dictates kind of who's my highest priority patients. Is speech seeing them for a swallow study? Are they gonna be gone? What meetings do all of us have? Our physical therapist is in the NICU. So what does my day look like? Because what I do highly involves our interdisciplinary team. So usually just from 9 to noon, seeing patients and charting, but it takes an interdisciplinary team to figure out what I'm doing. And then from 1 to 3:30, I'm seeing more patients. And then my hours are till 4:30, but I have to leave a little early anymore because my kids' daycare, I have to go pick them up. And I do my charting and check email at the end of the day, but then I'm seeing patients in those times and circling back. So 2 ICUs, I'm on our intensive care unit. So we get neurological, cardiopulmonary, surgical, trauma, and obviously with cardiopulmonary, we've had COVID. It ebbs and flows, let me just say. Part of the reason I love my job is I don't know what I'm walking into. We can have 4 patients discharged out of ICU and I never know what I'm getting the next day. It's interesting, you feel like there's ebbs and flows of caseload. Not that you should call it seasons, but like we have had I've had 5 neuro patients admit. You're like, what in the world? I have a neuro patient for like 2 months, what just happened? We got a lot of septic patients down here, post-surgical, so patients that need maybe a ventilator, or some vasopressors after surgery that come down here. And so I think that's the unique part though, is I get to, not one patient is the same. I'm seeing a variety of different diagnoses every day. Some more than others. I mean, when we were in COVID, I was literally seeing COVID patients all day long, which turns out can be a little neuro. So I dabbled in that a little bit. But yeah, it's very mixed. So here at Ball, I have the ability to wear physical therapy is ordered on any patient in critical care. They then have the ability to order me because the doctor signs off on that. So I'm still practicing under doctor's order. So I'm getting like 85 to 90% of patients in the ICU settings. One, I always get an occupational profile on everybody, whether it's from the patient or the caregiver. But then it all depends on what the diagnosis is. So for that patient that's down here for hypotension, I'm really monitoring what their blood pressure and vitals look like during ADLs and functional mobility. So sitting them up on the side of the bed and seeing what happens. For my neurological patients, I'm looking at vision. I'm looking at, my patients always mobilized. So most of the time on evaluations, I'm with a physical therapist depending on the level. And that's also really nice for a patient not to have to do all of it twice and answer all the same questions. So we sit them on the side of the bed. If they can do that, we stand. If they can do that, to a chair, to the bathroom. I'm always looking at ADLs, whether it's long sitting in bed donning a sock or walking them to the bathroom. For my neuro patients, I'm assessing functional mobility with vision. My higher level patients, I'm walking them in the hall and making them fine to look at higher level cognition and dual tasking. How are they following commands? Are they oriented? So cognitive screenings. For my ventilated patients, I basically go in and we usually coordinate with nursing when they're off sedation. And I'm trying to go in there and do exercises, their ability to follow commands. I'm doing early detection and screening for delirium. So we speak the same language as nursing when it comes to that. If the patient is, all their vital signs are stable, they can follow commands, we're sitting these people on the side of the bed intubated. And so evaluating anything they can do. Also, as an ICOT, my treatments are also continuing evaluations. I'm constantly evaluating what my patients do because people change so quickly. One day I'm walking the patient to the bathroom, the next day they're on, so especially with COVID, this would happen. One day they're doing great, and the next day they're on heated high flow, and then they're intubated. Well, my evaluation then just of that patient, I had to relook at everything, relook at my plan of care, redo everything. So I'm constantly evaluating down here, and I try to keep it as functional as possible. And really just trying to hit all of those client factors and everything I can to get a good picture of those patients, depending on the diagnosis. So I don't use a lot of equipment in ICU because a lot of what we're doing is just basic. So I use a lot of toothbrushes and toothpaste and washcloths, footies with that people get really confused why there's grips on both sides and don't know what up and down. Let me tell you, I had a patient the other day that was like, this is on wrong, the grips are on top. I'm like, just bear with me. So I do a lot of that. We do a lot of staying on the side of the bed. Walking to the bathroom, I use what I can. I use the towels and make people fold laundry. I had a lady that had a stroke and we just sat there and she folded laundry. I do have like exercise programs I'll bring down for patients. We have foam built up handles for interventions. Like I've had a lot of patients after critical illness that just can't feed themselves. So I do a lot of just adapting the room, looking at call buttons and a lot of visual management for these patients. Cognition is huge. So I work with our speech therapist a lot. And between her and I, just doing visual management and more intervention that way. And then patient and family education is huge. So one of the things I've done in our ICU liberation team is we have packets of information about delirium and sleep and post-intensive care syndrome. The power of education and just sitting down and talking with family is amazing to me. And so one of the things that I've gotten better at is sitting down and really taking the time and explaining everything I do. Huge. Why are you making me fold a towel? Why are you making me walk to the bathroom when I don't have to go? And then you sit down and I actually do have to go because that always happens. Why are you making my husband get up on a ventilator? That seems ridiculous. He's on life support. Well, let me tell you why. We do use, we have lifts in every room. So if I can, me and the physical therapist lift all of our patients up to a chair. Helps with feeding when they're extubated. It helps with just breathing mechanics, activity tolerance. I can get some really good arm movement when they're away from the bed, and overall helps their cognition and alertness. We also use a tilt table. So my low-level brain injury patients, just getting that proprioception. So one of the things I should mention, so sitting someone on the side of the bed is really sensory stimulation if you think about it. And if you lay in bed for a while and your hemodynamics aren't used to it, that change in position, that is a change in proprioception. So a lot of what I do that I don't think we realize what I do is sensory stimulation. I knew I wanted to work in a hospital setting. I didn't have ties to Indiana until I went to Vanderbilt. They did not tell me I was going to be though in an ICU until I got there. And I remember going in the first patient's room. I can remember her like it was yesterday. And she had been in a motor vehicle accident. She had a head injury. She was trached, had everything. I called my mom and was like, I can't do this. What in the world? They don't teach us this in school. Like, I cannot do this. I fell in love. I fell in love with it. I completely fell in love with everything about it. And the physical therapist there at the time, who actually did research with one of the physicians at Vanderbilt, goes, do your student project on early mobility in the ICU. Okay, fine. They ask you to do projects. I started looking this up. I'm like, there's research around this. Like, this is good stuff. And it actually helped me get the job at Ball. So Ball didn't have an ICU program. And so I remember on a whim looking up, there was a the Hopkins conference in Baltimore, and I'm like, okay, it's like $300. I can't afford this. I'll ask if they'll pay for it. Ball paid for it. And I flew out to Baltimore by myself in this huge auditorium, and I was like, what did I just do? Like, this is, oh my gosh, the hotel, the whole experience is kind of crazy. I had never used a taxi service before, like the whole thing. And I came back to Ball and was like, I'm going to do this. And if they pay for a course, they have you do an in-service. So I did an in-service, so how awesome early mobility was. One of the therapists that had been there a while, she was a physical therapist, came up behind me and patted me on the back and said, we've already tried this, good luck. And I was like, okay, that's welcoming. I'm going to do this. And I went to the nurse manager of ICU and I said, I want to do communication evaluations and I want to see your patients, but they have to be off sedation. Can we do this? He then went to the clinical nurse specialist and we formed our ICU liberation team that I've been the therapy representative, and that ignited what we do now. Vanderbilt shaped me to want to do critical care, but it was one little idea, knowing it was best for the patient and the advocacy for that then led to everything I do now. And I tell that a lot, but it's amazing to me how important it is that you don't forget they're human beings and they need the evidence-based practice. And so one little idea has literally turned into now 5 therapists in ICU doing everything. My second memorable moment probably has to be November 16th of 2021 when we started our support group. I might cry, but I'll hold it together. I've worked with critical care patients for a long time, and you don't really realize how you touch people until they come back and they call you their family, and they come back to you and they tell you like you saved their life. Therapy, especially in the acute care setting, and especially what I do, think about OT and ICU where I see people in their vulnerable state, toileting, hygiene. I mean, come on, we are in these people's business. During COVID, they didn't have family here. We were their family. I followed a patient throughout the hospital, and me and the physical therapist were the only 2 people that were consistent from the day he got here to the day he left. And we started a support group, and John and Kathy come to support group, and John and Kathy call me family. And I think to be that person that they can be vulnerable with and you're helping them. I mean, I helped the man regain the ability to be able to go home. We rehabbed him to the point where he could go home. He shouldn't have gone home, but long story. But to where he was laying in a bed and he remembers my voice for the first time, and he'll tell that story over and over and over again. He's just one person, and I've had so many more of those with COVID, and I've had so many in my career of the patients, but I don't think up until support group and hearing just how much it means to people that our profession touches so many lives, and just to be that person, and especially in the acute care setting, people are scared. Where I work in the intensive care, sometimes we don't know if the patient's gonna live or die. And helping them and being a part of that journey, I think is just one of the truly amazing parts of my job, and I just love what I do. We didn't learn about this in school. You learn about acute care, but I don't want to say it's an emerging practice area. There's a lot of OTs working in ICUs, but PT dominates. I will say what's unique about where I work in this setting is that I am a highly valued team member as an OT. Highly valued. And they value everything I have to offer as an OT here. I do feel like I have talked to many therapists throughout my years as an ICU therapist, and it is a very PT-driven world. The research is very heavily around early mobility. Early mobility. Well, that's great, but I can also complete early mobility, and I can also have people up to the bathroom, and I also have a different lens that I can see these people through. And so the unique part is I've advocated for our profession here, and so I've made a voice, and I'm at the table, and an OT is always at the table around here when it comes to ICU. I also think it's unique because people people don't understand therapy this early on. I didn't understand it, and families get very concerned when I come in the room. They don't understand. But if you take the time to explain why you're in the room, it's amazing. There's such a stereotypical ICU that we see on Grey's Anatomy, or we see on Scrubs. I don't even watch any of this. That people forget that the goal when you come here is to get you off a ventilator, to get you home, and that is what we strive for here. And so I do say, OTs everywhere, make your voice heard.